Hello everyone. This module is titled Keep Calm and Okay Not That Calm, and this is an EKG review for the Emergency Medicine Board exam. Everything that is on the exam should pretty much be covered in this PowerPoint video. I will be going pretty quickly through this just as there's a lot of information to cover, but at any point in time, if you feel you need to stop, pause the video, kind of read over the slides, feel free to do so. So let's get started. So the way I kind of basically laid out this talk is just separated everything into different categories, which are listed here: too normal, too slow, too fast, too wide, too high, too low, too toxic, too metabolic, too scary, and too paced. So starting with normal EKG, most people here should be listening to this video should already be kind of aware what a normal EKG looks like, hopefully. If not, you can review the criteria right here. And in this slide, I just listed the age-appropriate rates for sinus rhythm for all age ranges, basically going from the newborn to about 6 years old. After around 6 years old, they should have a heart rate essentially the same range as an adult patient. So here's just an example of a normal EKG. So let's get started with our first real topic, and this is going to be our too slow topic, and it's going to focus mostly on bradyarrhythmias. So these are the, I'd say the three, big categories that you should really focus for the exam that you might see on the EM boards. It's going to be your sinus bradycardia, junctional bradycardia, and then your heart blocks. So focusing on sinus bradycardia, obviously this is any resting heart rate that's going to be less than 60 beats per minute, and there's tons of different causes for this. And here I have listed the non-pharm causes as well as the pharmacology causes. So any kind of medications, especially like any kind of antiarrhythmics, antihypertensives, are going to be something you want to always look for when you see sinus bradycardia in the exam. And here you could see just a basic example of sinus bradycardia. Obviously the rate here is pretty slow. You do have your P waves, everything else looks sinus, so it's regular rhythm and everything. So next let's move on to junctional bradycardia. Typically your junctional bradycardia, your rhythm is going to be around 40 to 60 beats per minute. You're still going to have your narrow QRS complexes, but when you have a junctional rhythm, you're really not going to see P waves. They're either going to be missing or they're going to occur immediately following the QRS. We call these retrograde P waves. Typically with the junctional, you're not really going to see any relationship between the QRS complexes or any preceding atrial activity. And one pearl here, whenever you see this junctional type bradycardia, you always want to consider a possibility of Digoxin toxicity or hyperkalemia. So just looking at a junctional rhythm here, you can see this is pretty slow bradycardic rhythm, but there's no visible P waves prior to the QRS complex. If you look at the yellow arrow here, you do see it's pointing to a P wave, which is actually coming after the QRS complex, so this is a retrograde P wave. So this is a great example of a junctional bradycardia here. So moving on to heart blocks. Heart blocks can essentially be caused by just about anything, but the things we really want to look for are things like ischemia, especially inferior ischemia. Any kind of AV nodal blocking drugs are going to be your big causes of this. For the heart blocks, we typically categorize this into first, second, and third degree, with second degree having type 1 and type 2. First degree AV heart block, basically all you have to know for this is it's going to be a PR interval that's greater than 200 milliseconds. There's not a lot of pathology associated with this. Like I said, it can be caused by ischemia, AV nodal blocking drugs, but really asymptomatic most of the time. Nothing you really have to do for this. Moving on to second degree AV block, we're going to start off with type 1, which is Mobitz type 1, also known as Wenckebach. This is a progressive prolongation of the PR interval, which culminates in a non-conducted P wave. Basically what you're going to look for here is you're going to see a PR interval which continues to get longer, longer, and longer until you have a drop beat, and then it starts all over again. The PR interval is going to be longest before the drop beat and shortest right after the drop beat. So just things to look for there. This really, once again, usually asymptomatic, no real treatment to do, just monitor the patient, have them follow up. So next we have our Mobitz type 2 second degree AV block, and this is one we really need to be careful for and look out for. This is a basically in Mobitz type 2 you're going to have intermittent non-conductive P waves without progressive prolongation of the PR interval. So here you're going to have PR interval and conducted beats that remains constant. This is bad because this can progress to a third degree AV block, which is something we don't want to progress to, as that can be associated with cardiac arrest and death. So what is the treatment for this when you see this? You're basically going to admit this patient for cardiac monitoring, have a backup temporary pacer on them just in case, and ultimately they're going to need insertion of a pacemaker. And as you can see here with the EKG, you have your basically your drop beats as well as a constant PR interval. So moving on to third degree AV block. This is another bad one, of course, and this is basically the absence of AV conduction. Perfusion here occurs mostly by junctional or ventricular escape rhythms. It is independent atrial and ventricular rates. So when you look at the EKG here, you're going to see that the atrial beats, so the P waves, are going to be constant, and the ventricular beats are going to be constant, but they're not associated at all with each other. They're kind of beating independently of each other. And a good way to kind of just, if you're having any issue with this when you look at the EKG, is just kind of put little marks like they did here, little arrows at the P waves and at the QRS complexes, and you can see how there's pretty much a constant interval between the QRS complexes and the P waves, but there's no association between the two. Treatment for this is same as Mobitz type 2. Obviously, this is bad. People could come in very bradycardic, very symptomatic. You want to basically pace them if you need to, admit them, and they're going to need a pacemaker insertion. So let's move on to some questions here. Question 1, we're going to have a 65-year-old woman who presents with weakness. Vital signs include a blood pressure of 70/30, a pulse of 35, respirations of 18, a temperature of 37.3, and an O2 sat of 95% of room air. On exam, lungs are clear and the femoral pulses are weak. Blood glucose level is 105 milligrams per deciliter, and an EKG is obtained. A 1 liter normal saline bolus is ordered, and there's your EKG right there, so you can take a look at that. So, which of the following should it be administered next? A. Aspirin, B. Atropine, C. Epinephrine, or D. Transvenous pacing? So, the answer here is going to be atropine. And why is that? Well, looking at the EKG, this is a junctional bradycardia here. As you can see going back, there's no visible P waves while looking at the EKG here, and it's very bradycardic. As we talked about, patients hypotensive and weak. So the initial treatment for a patient like this would be atropine and transcutaneous pacing. Now, some of you might have thought transvenous pacing would be the correct answer here, but that is a pretty time-consuming procedure to do. And with a patient who's becoming slightly more unstable, you really want to throw those pacers on just transcutaneously first. Obviously, atropine, you could try that as well. You should pretty much be doing these simultaneously, not one before the other. But in terms of this question, the best choice would be atropine. So moving on to the next section, too fast, we're going to go over tachyarrhythmias. I separated this into your regular and irregular tachyarrhythmias, and I focused mostly on just the narrow complex ones in this section. So speaking with irregular, we have our sinus tachycardia, SVT, and atrial flutter. And when we talk about more irregular tachycardias, we're going to talk about our atrial fibrillation, our multifocal atrial tachycardia, or MAT, and our atrial flutter with variable block. So getting started just with sinus tachycardia, this is going to be a sinus rhythm with a resting rate greater than 100 beats per minute. For differential for this type of an arrhythmia, obviously it can be anything that causes increased heart rate. Things like pulmonary emboli, hyperthyroidism, different kinds of drugs, hypoxia, you name it, it can cause it. One pearl that I always like to kind of throw out there with sinus tachycardia is the rate should slow down with fluids or fever reduction. So if you have someone who's coming in super tachycardic, you're giving them fluids, their tachycardia is just not changing at all, or you give them Tylenol, their fever goes down, and they still are tachycardic, you want to think that there's something else going on here. And here's EKG here of just basic sinus tachycardia. As you can see, there are P waves before each QRS complex, so those are easy to see. And that's obviously something that you always need to have in order to diagnose sinus tachycardia. Just talking about pulmonary embolism real quick. And the reason I bring this up now is because about 30% of people who have a pulmonary embolism will demonstrate sinus tachycardia, and that's typically the most common abnormality you will see on EKG. You can also have some non-specific ST segment abnormalities. And then the one they usually test you on the exam is going to be this S1Q3T3 pattern. However, you only see this really in like 10 to 15% of EKGs in people who have pulmonary emboli. So I'll show you an example of that right now, just so you can kind of, make sure if you see this on exam, this is pathognomonic basically for pulmonary embolism on exam. You might have someone coming in, their shortness of breath. They give you this EKG, and you're going to see in, your lead 1, you're going to have this, deep S wave, and then in lead 3, you're going to have your Q wave and your inverted T wave. So if you see that, it's going to be associated with pulmonary embolism on exam, like end of story. They're giving it to you there. So the next arrhythmia we're going to talk about is going to be your supraventricular tachycardia. Usually when you say SVT or supraventricular, we're speaking more about an AV nodal reentrant tachycardia. This is going to be a very regular, narrow complex rate of 150 to 200 beats per minute. You're not going to see any P waves, and that's very important to know. If you have a rhythm that's fast and there's no visible P waves, it could be, sinus tachycardia and the P waves are just getting sunk in. But really, there's going to be hard to tell between that and SVT. So if you have a known SVT, what is how you're going to treat this? So they come in, they're very unstable, very hypotensive, altered. You just want to cardiovert this person electrically, just get them back in normal sinus rhythm. If they're stable, there's a couple other options we can try. A lot of people like to start off with vagal maneuvers, and these, they can be pretty successful, especially in younger children. This terminates about 20 to 25% of SVT, so not too bad. And obviously, you don't have to push any medication, so that's always good. The next drug of choice, or treatment of choice, is going to be adenosine. It's typically, they might ask you about this on exam, but you're going to give about 6 milligrams. Wait a couple minutes. If there's no change on the EKG, follow this with another 12 milligrams of adenosine. Hopefully, that will convert the patient. You want to make sure that you give this very rapidly. Follow it by 20 milliliter of saline flush, and if you're putting it in the arm, you want to elevate the arm. You always want a nice kind of big vein for this, so you want to have like a nice antecubital vein, nothing in the hand or anything like that. Other agents you can use for this, calcium channel blockers, beta blockers, amiodarone, and procainamide. And here's just a EKG here of a SVT, supraventricular tachycardia. If you look carefully, you'll see the absence of P waves here. It's got a good rate, going about 150 beats per minute. It's constant, it's regular. That's SVT in my book. So moving on to atrial flutter here. This is going to be another regular neurocomplex rhythm. And typically it's going to have an atrial rate of 250 to 350 beats per minute. However, the ventricular rate can vary. This is going to have your typical sawtooth appearance, which we're all pretty familiar with. You're going to see the sawtooth best in leads 2 and V1. So if you're having difficulty determining if this is atrial flutter, kind of look in those leads, they're going to help you the best. Often this is going to be like a 2-1 block, which is going to give you a ventricular rate of 100 beats per minute. So once again, if you're looking at EKG and you got a rate of 150 beats per minute, you want to make sure you're considering atrial flutter here. If you are having a kind of a difficult time, one good pearl is, give a little bit of adenosine, and it actually can reveal the underlying rhythm here, which is going to be your atrial flutter. Sometimes this can present with a variable block, which can make the rhythm look very irregular. So atrial flutter can be both a regular rhythm as well as an irregular rhythm. Treatment for this, if they're unstable, boom, cardiovert them, just like most other rhythms with unstable patient. If they're stable, you could try beta blockers, calcium channel blockers, digitalis, anything like that. And here you go is atrial flutter with the sawtooth pattern there. And you can see that's a 3 to 1 block. And then I just wanted to show you an example of atrial flutter with variable block here. If you didn't see the flutter waves, it could almost look like an atrial fibrillation. But you can see it goes variable block. There's a 2nd degree, 3rd degree, 4th degree block. And that could present like that as well. So moving on, everyone's favorite, atrial fibrillation, very common. In the emergency department, we see this all the time. This is a narrow complex known as an irregular rhythm, tachycardia, with no distinct P waves. Acute causes for this, sometimes they'll ask about this a lot, or this could be triggers. ETOH, alcohol intake, they call it like holiday heart syndrome, any kind of myocarditis, pericarditis, any kind of inflammation of the cardiac muscle, pulmonary embolism, hyperthyroidism, acute myocardial infarction. Different drugs can cause this, acid-base disturbances, and pre-excitation syndromes like Wolff-Parkinson-White. Treatment for this, once again, unstable, cardiovert them, and if they're stable, you can use a calcium channel blocker like diltiazem, beta blocker, amiodarone, or digoxin. In terms of converting to sinus rhythm, typically we like to do a rate control approach in the ER. This should really only be attempted if the patient is either acutely unstable, if the duration of the symptoms is less than 48 hours, or if the patient has been anticoagulated for at least 3 weeks before, and then they'll be anticoagulated for at least 4 weeks after cardioversion. And in case anyone's not familiar with that, here's a typical example of your atrial fibrillation EKG. As you can see here, it's a very irregular neurocomplex rhythm, no really distinct P waves, very yeah, very typical atrial fibrillation EKG there. Another irregular rhythm tachycardia is going to be your multifocal atrial tachycardia, and really in this one you're going to have the way you diagnose this is you're going to have P waves, but they're going to be distinct morphologies. So sometimes this can look like atrial fibrillation, but if you look carefully, you'll see that there are P waves before every QRS complex. And when you see this, what do you want to think? You know, if you see an EKG like this, typically, you know, the case is going to say it's older gentleman, have history of significant COPD or significant severe CHF, and this is going to be the rhythm that they have. So if they ask you about management, how to treat this, really what you want to do is treat the underlying condition. Death is not really going to occur secondary to this arrhythmia, but it's going to occur secondary to whatever horrible hypoxia or COPD or CHF exacerbation they have. So the rhythm's not going to kill you, so really just treat the underlying condition, and a lot of times this rhythm will actually go away once you treat the patient. And here's just an example of your MAT here. As you can see, I kind of marked out a couple of the different P wave morphologies, but you can see prior to every QRS complex you do have a P wave, even though, you know, one of them looks like it's inverted, another one's kind of tall, another one is more normal, but these do repeat throughout the process, and there's at least 3 of them, so we can diagnose this as a MAT. So moving on to some more questions here. So question number 2. 29-year-old woman presents with palpitations. She denies any chest pain, shortness of breath, or lightheadedness. Vital signs are blood pressure of 110/70, pulse of 180, respirations of 16, temperature of 37.8, and O2 saturation 97 on room air. An EKG is obtained, and I'll give you a second to look at that there. So a question here is, what is the initial intervention of choice to address the palpitations? We have A, amiodarone 150, B, metoprolol 5 mg, C, synchronized cardioversion, or D, vagal maneuvers. And the answer we're looking for here is going to be vagal maneuvers. So really in a patient with basically stable SVT, things you want to try first could be vagal maneuvers versus adenosine. I'll typically try to have perform the vagal maneuver first, and then if that doesn't work, move on to adenosine. Obviously for unstable, then we would go to our synchronized cardioversion, but in this patient, try vagal or adenosine first. So next question here. 8-month-old females brought into the ER for evaluation of vomiting and diarrhea of 36 hours duration. Vital signs include pulse of 195 beats per minute, respirations of 32, temperature of 37.1, and O2 saturation of 98% of room air. The nurse is concerned about the patient's heart rate and gets an EKG, which you can see right there below. Very fast rhythm. So the question is, what is the best treatment for the infant at this time? A, adenosine, B, digoxin, C, normal saline bolus, or D, synchronized cardioversion? Okay, so normal saline bolus. So why do we say that here? Well, when you go back and look at the EKG, you could see that there are some, it's kind of hard to see with a small image, but there are P waves which are visible, especially like in lead 2. If you look prior to the QRS complexes, on the T wave you could see a P wave there. So really with this, we don't want to give this kid adenosine, try vagal maneuvers. You want to, they're very dehydrated, they haven't been consuming fluid for the last 36 hours. So this is likely tachycardia secondary to hypovolemia. So once again, P waves, hypovolemic, give some fluids first and see how the patient does there. Okay, so moving on to our next section, too wide. Speaking about widened QRS complexes. So really, for the exam, I'd say there's like 6 causes of wide QRS you really need to kind of be aware of. 1 is going to be our bundle branch blocks. 2 is going to be hyperkalemia, which we'll discuss in the electrolyte section. 3 is going to be your ventricular rhythms. 4, medications, which we'll discuss in the tox section. 5 is going to be any kind of paced rhythm, which we'll discuss in the pacemaker section. And then 6, Wolff-Parkinson-White Syndrome. So just a quick review of left and right bundle branch blocks. These are caused by disruption of conduction or depolarization on the left or right bundle branches. Left bundle branch block causes, you can see there as well as right bundle branch block. And when looking at left bundle branch block, just a quick and dirty way to kind of if you're not familiar with seeing this type of pattern, look in basically leads V1 and V6. If you see a dominant S wave in lead V1 and a broad kind of monophasic R wave in V6, this is most likely going to be your left bundle branch block. For your right bundle branch block, you're going to have a RSR prime pattern in V1 to V3, and then a wide slurred S wave in V6. So I think most people are pretty familiar, with both left bundle branch and right bundle branch block patterns on EKG, but in case you're not very familiar with it, just take a second to kind of look at these and familiarize yourself with them. One issue with left bundle branch block, and I think the biggest thing for the exams is typically they're going to show you a left bundle branch block, and the patient's going to be coming in with significant chest pain, and they're going to say, like, should you take this patient to cath lab, or should you just treat them conservatively? And really, the answer for that on the exam is going to be, especially if they say the patient had an old EKG, which was normal. Now they come with a new left bundle branch block and chest pain. Really, it's going to be taken to the cath lab, because that's going to be essentially STEMI equivalent. You can use the Sgarbossa criteria, which is basically can be used in individuals with a known left bundle branch block to really help assist you with diagnosis of MI, and I have that kind of laid out here for you, so you can review that if you want. But for the exam, I think it's going to be a little bit more clear than that. It's going to be, like I said, a patient with a new left bundle branch block, and they're going to basically be testing on whether this, that meets STEMI criteria. And I think, for now, for the exam, you should say yes, go to cath lab. So moving on, ventricular tachycardias. You're going to have, more your monomorphic ventricular tachycardia, which is just your kind of basic V-tach. Then you also have polymorphic ones. And the one we really want to kind of know for this is going to be your torsade point. And then we have our ventricular fibrillation. So just going over monomorphic V-tach. It's going to be a broad complex tachycardia originating in the ventricles. Rapid heart rate, typically around 120 to 140 beats per minute. Very broad QRS, and obviously this is what's going to separate it from your neurocomplex tachyarrhythmias. And then you can also see things like AV dissociation, capture beats, and fusion beats, which I have some examples of on the next couple slides. Obviously, treatment for this, if they have no pulse, start your ACLS, CPR, defibrillation, etc. If they're unstable, but they have a pulse, go straight to cardioversion. And then if they're stable, you want to consider things like amiodarone, which would be first line. Other agents could be procainamide, sotalol, lidocaine. And here's an example of your kind of monomorphic V-tach. All the QRSs are pretty much the same width, same length. Here's an example of AV dissociation. And as you can see by the arrows, you can see the P waves that are kind of popping up. And then here's an example of your capture beats and your fusion beats, which you can take a look at. So moving on to polymorphic V-tach. The big one here that we want to know is our torsade point. This is going to be, multiple ventricular foci, which result in these QRS complexes that are just very varying, twisting, rotating complexes. And this is really, the thing that you're kind of basically going to want to know here is that this is associated with a prolonged QT. So you have this prolonged QT, and then, you're basically you have a complex which triggers on the QT, and this sends it into torsades. Causes for this, any kind of electrolyte abnormalities, especially things like hypomagnesemia are the big one that they'll usually test you on. All 1A antiarrhythmics, things like procainamide, quinidine, disopyramide, and then any psychotropic drugs. TCAs are the big one that they'll kind of test you on for the exam. And then treatment for this, magnesium sulfate is going to be first line. You can do cardioversion as well, but really on the exam, you see torsade, you see it, in a rhythm on an EKG. Most of the time, they're probably going to ask you, how do you want to treat this? And your answer should be magnesium sulfate. And here's an example of kind of someone who's having a rhythm, a little bit prolonged QT, and they kind of went into this torsade, varying, twisting rhythm where, the V-tach QRS complexes are wide, but they kind of shrink and then expand and shrink and expand. So this is, something you really want to be looking out for, because that's easy points right there. So continuing on, Wolff-Parkinson-White Syndrome is the next cause for QRS, wide QRS complex. This is really the most common form of pre-excitation syndrome, and it's basically characterized by the presence of an accessory pathway known as the bundle of Kent, and it is also associated with various tachyarrhythmias. Basically, keyword here, delta wave pattern. I'm sure most of you have seen this before as well, and I'll just point it out here on the EKG. You have this wide QRS complex with this very short PR interval, and it has this kind of like upward sloping, which looks almost like a delta, which is basically looks like a triangle. So typically with this, things they might ask you about are you can have AV nodal reentrant tachycardias with this. And things you really want to know is that there's two types. So you can have your orthodromic or your anterograde or your antidromic, which is your retrograde. And for orthodromic tachycardia or AVNRT, basically the rhythm's going to go down the AV node and then up the basically the accessory pathway. And this produces basically just a normal narrow tachyarrhythmia with a very narrow QRS complex, and the treatment for this would be just like any kind of other SVT, try vagal maneuvers, give adenosine, try to get them back to normal rhythm. On the other hand, you have your antidromic AVNRT or AVRT, which is basically going to be where the signal goes down the accessory pathway and then back up the AV node. And this is going to give you more of a, typically it's going to give you more of a wide QRS, and it's almost going to look like a V-tach, or basically it's going to be a V-tach. And if you know that the patient has a history of WPW, obviously you don't want to give adenosine to these patients. You want to give them procainamide. It's going to be the answer of choice for the exams. You want to avoid any kind of meds that are going to block the AV node, so any kind of digoxin, calcium channel blockers, beta blockers, and as we said, adenosine. Avoid that. That's not going to be the right answer for that. And here's just an example of the orthodromic. So this is going down the AV node. So it looks just like kind of any kind of SVT. So treat that with adenosine, vagal maneuvers. And then here's your antidromic. And you can see you kind of have this like wide V-tach looking thing with kind of like variable width of the QRS. And especially if you know that there's a history of WPW, like this is, very typical for antidromic. You want to treat this with procainamide, especially if they're stable. So moving on to some more questions. Question number 4 here. We have a 69-year-old male presents ER with left-sided chest pain and shortness of breath at rest. He says that the symptoms started about 5 hours earlier. Vital signs include a blood pressure of 110/68, a pulse of 100, respirations of 18, and O2 at SAT of 100% of room air. Physical exam is unremarkable, and the EKG is obtained. Okay, there's EKG there. So which of the following additional findings supports emergent percutaneous coronary intervention? A, contrast eye allergy. B, normal coronary catheterization 1 week earlier. C, normal intraventricular conduction on prior EKG. Or D, resolution of pain without treatment. And the answer here is going to be normal intraventricular conduction on prior EKG. And really, like we talked about, if you have a new left bundle branch block and active chest pain, this is basically going to be a STEMI equivalent. You're going to want to take them to the cath lab right away. So going back to this patient, the EKG shows a left bundle branch block. Basically, so they're saying if you have, if this patient comes in and they have a known prior EKG, which does not have one of these, and they're actively having chest pain, you have to treat this as a, as a STEMI. Okay, question number 5. A 25-year-old man presents by ambulance following a 911 call. His girlfriend told the operator that he said his heart was racing and then he started acting out of it. When paramedics arrived, he was hypotensive, and the cardiac monitor showed a neurocomplex tachycardia. He was electrically cardioverted on the scene, so sinus tachycardia. On physical exam, mental status and vital signs are normal. And there's EKG. So which one of the following statements regarding this cardiac condition is correct? A, atrial fibrillation is the most common tachyarrhythmia associated with this condition. B, electrical cardioversion should be used for a patient with this condition who presents with hemodynamically stable tachycardia. C, procainamide should never be used for wide complex tachyarrhythmias associated with this condition. Or D, when paroxysmal supraventricular tachycardia occurs with this condition in a stable patient, adenosine is an appropriate therapy. So the answer here is going to be D. And why is this? Going back to the image, obviously this looks like a, delta wave here pattern. So we're thinking WPW. Likely, this patient was in some kind of tachyarrhythmia. So as we said here, if we have a narrow complex, basically regular SVT for a patient who has WPW, adenosine is okay. Once again, procainamide, if known WPW with a stable patient is okay, or if they have a wide complex tachycardia, that's the medication that we'd like to use. So moving on to our next section, which is going to be titled Too High, which is going to cover our ST segment elevation. And just like in our other section, there's really 6 causes of ST segment elevation that we need to know for the exam. Going down, this is going to be our STEMIs, benign early repolarization, pericarditis, left ventricular aneurysm, Prinzmetal's angina, and bundle branch blocks, which we discussed earlier. So STEMI, this is the big one. This is the one we're going to see in the ER, the one that, obviously we need to, diagnose very quickly in order to, save a patient's life. So just kind of covering the criteria for this, which is the criteria for STEMI and indication for PCI and thrombolysis. By the books, basically, if there's any kind of ST segment elevation that's greater than 1 millimeter in 2 contiguous limb leads, or or greater than 2 millimeters in 2 contiguous chest leads, then any type of bundle branch that's blocked that's thought to obscure the ST segment analysis in a patient with clinical presentation strongly associated with, acute myocardial infarction. This is someone we want to, basically call STEMI as well. Other EKG findings that are highly associated with STEMI are going to be reciprocal changes, so like ST segment depressions and kind of other leads, and then any kind of evolution change from previous old EKG is going to be concerning for STEMI. And the thing you want to look for is a lot of people get confused with the elevation. How do I know if this is benign early repolarization versus a STEMI? You want to look for that kind of like frowny face appearance. So as you can say here with the little smiley or this frowny face, that's more consistent with your your STEMIs as opposed to your other causes of ST segment elevation. And here's just some slides to kind of show the different types of infarction based on the leads. So your heavy green is going to be your basically your lateral, your yellow is going to be your anterior, and your blue here is going to be your inferior. Okay, and this is just a really nice table that shows kind of the area of the MI based on the EKG. So I'm not going to go over this, but you can pause if you want to take a look at it. It just shows the EKG leads, the area that's affected, the artery that's typically causes this, and typical complications that can arise from this. Just going over some pictures here. This is a very classic presentation of an anterior STEMI. As you can see here, leads V1 to V4, pretty good elevation. Lateral STEMI here, very easy to see, in leads 1, AVL, leads V5, V6, you have some pretty good elevation. Reciprocal changes as well in the other leads with ST segment depression. So just to talk a little bit about inferior STEMIs. So up to 40% of patients with inferior STEMI will have a concomitant RV infarction. So this is something you always want to think about when you see an inferior STEMI on EKG. Additionally, up to 20% will have significant bradycardia associated with a 2nd or 3rd degree AV block, as the artery that supplies this area also supplies the AV node most of the time as well. And then also this can be associated with the posterior MI. Here's a picture of inferior STEMI, and if you look at leads 2, 3, and AVF, you can see pretty significant elevations there. So just talking a little bit about posterior STEMI here. Like I said, this is seen in inferior lateral MIs. It's suggested by the following in leads V1 through V3. So those are really the leads you kind of want to look in for posterior STEMI. Any kind of like horizontal ST depression, so horizontal, flat ST depression in those leads. You want to have tall, broad R waves, upright T waves, and a dominant R wave in V2. If you see any of these things, it should be extremely concerning for posterior MI, and you want to place posterior leads on this patient. So here's a posterior, kind of a hint of a posterior STEMI. So if you look in leads V1 through V3, you can see this very flat ST segment depression with these upright T waves and a very large kind of like R wave and lead V2 here. So that. And just kind of going back here, here's your normal EKG for your posterior STEMI that you're concerned about. You get a posterior lead 1, and now you have V7, V8, V9. You see obvious ST segment elevation there, and obviously you're going to call STEMI on that. So right ventricular infarction, this is another one that can occur with inferior STEMI. And hints for this, you're going to have ST segment elevation in leads V1, and you're also going to have ST segment elevation in lead 3 that's going to be greater than lead 2. which is typically not the case. The thing you really want to know about this is that it's extremely sensitive to preload. So nitrates are bad for this. If you give nitrates to a patient with right ventricular infarction, you're going to completely drop their preload and they're going to tank and go in the wrong direction. So with a patient like this, you want to give fluids, not nitrates. If this is an obvious inferior infarct here, you're going to take this patient to the cath lab immediately. So not too big of a deal. But if there is concern for RV infarction in a patient who's not going to be going to the cath lab, you want to obtain those right-sided EKG leads before starting any nitrates on the patient. So obvious infarction, they're going to go to cath lab. If not, get the EKG leads before you start nitrates. And here's an example here of your elevation in V1. And then your elevation here in lead 3 is greater than lead 2. So those should all be concerning for, right ventricular infarction. You get your, your right-sided leads here and you look at V4 and you're going to have elevation there. So just a few STEMI pearls. If cath lab is available, door to balloon time 90 minutes. If stable, don't delay. They might say like, patient developed this, well, waiting to go to the cath lab. Do you want to give them amiodarone or something else? No, if they're stable, they got to get to the cath lab. That's the only thing that's going to truly save their cardiac muscle and, give them a chance to survive this. If the cath lab is unavailable, you can give them thrombolytics, and the door to thrombolytic time is about 30 minutes. And then once again, avoid nitrates and right ventricular infarct. Make sure you give IV fluids to these patients. So next, benign early repolarization. You really want to think of like young, healthy patients that come in. They're going to give you EKG. It's going to have some ST segment elevation, but they're going to be young, healthy, asymptomatic patients. You're going to see some mild ST segment elevation with tall T waves, mainly in the precordial leads. You're going to see a little bit of a notching of a J point, causing what we call fish hook-like pattern. And this is often associated with left ventricular hypertrophy as well. This does not evolve, so if you get multiple EKGs, it's going to look the same every time. It's going to be present on old EKGs. So this is not a STEMI. And here's your smiley face here. So unlike the STEMI we talked about with frowny face, benign early repolarization is going to have more of a upsloping smiley face pattern. And as you can see here, you have a little bit of a fishhook sign. And here's just an example of EKG with benign early repol, kind of showing all those different features. So moving on to pericarditis, something very commonly, very tested on the exam. Most likely you will see an EKG of pericarditis. This is going to be a widespread concave saddleback like ST segment elevation, diffusely throughout the EKG, additionally with PR segment depression. Causes for this, most commonly it's going to be viral or idiopathic. You can see it also in like post-MI, infectious, radiation, trauma. You really want to think of a patient that's going to be coming in with sharp pain, which is going to be improved with sitting up and leaning forward. Typically, it will have a history of like a viral illness or MI several weeks previously. On physical exam, they might mention that you hear a friction rub. And if there's really no specific cause for this, basically the treatment's going to be NSAIDs. And here's just an example of EKG with pericarditis. As you can see, you have this very like diffuse ST segment elevation, kind of almost in every single lead. And then if you look especially at the red arrow here, you can see a nice example of some PR depression. All very suggestive of pericarditis, especially with the clinical history. So moving on, left ventricular aneurysm. This is another cause for ST segment elevation. And even though they call it an aneurysm, it's not really a true aneurysm. Really what happens is you'll have anterior myocardial infarction, and you'll get some scar tissue in an area. And then what happens is this scar tissue kind of degrades a little bit. During systole, you'll kind of balloon out and create this like pseudo-aneurysm. And on EKG, what this is going to look like is going to look like a STEMI in leads V1 and V2. So you're going to have elevation in these leads. Other ways to kind of differentiate this or to notice, if they don't mention that there was a history of an anterior STEMI, you might want to look for Q waves in leads V1 to V4, as this can be a sign that there was a previous anterior STEMI. Additionally, there's going to be a lack of any new changes. So if you have an old EKG and then this one and they're the same, obviously there's no progression, no evolution. And then you're really not going to see any reciprocal depression in any other leads. I think for the exam, they'll probably show you this and they'll probably give you the history that this patient had, a recent MI, and they're coming in now possibly asymptomatic. But this is the EKG that they have. They're going to ask you, do you want to take this patient to the cath lab? The answer is probably going to be no, based on the history, based on the clinical you want to get echo for this patient or something like, in that respect, to look to see if there's any kind of a, ballooning or aneurysm on, that exam. So here, just looking at the EKG, looking at leads V1 and V2, you see there's this, ST segment elevation there with some nice deep kind of Q waves and leads V1 through V4. No other reciprocal changes in any of the other leads. So Prinzmetal's angina. This is basically secondary to vasospasm. It looks like a STEMI, but it's transient, so it comes and goes. For this one, think a young person, healthy. Maybe they have a history of cocaine use. They come in, you get an EKG, it shows some ST segment elevation, and then they improve. Basically, this is reversible with vasodilators. That's pretty much what you want to look for in, this patient. Let's go over some questions here. So question number 6, 62-year-old man, history of hypertension, diabetes mellitus, presents with chest pain and shortness of breath for several hours. An exam, he appears diaphoretic. Vital signs are BP of 80/50, pulse of 110, respiration of 20, and O2 sat of 94% of room air. An EKG is obtained. Give it a second to look at that there. So which of the following is the appropriate definitive therapy for this patient? Give them a bolus of normal saline, start them on a dopamine drip, have them have primary angioplasty or thrombolytic therapy. So, primary angioplasty, surprise, surprise, that's the correct answer. So what are we seeing in this EKG? Going back here, this is, you have some nice elevations and leads, V1, V2, V3, maybe V4, even going down into V5. Possibly some reciprocal changes and other leads. So this is an anterior STEMI. So the treatment of choice for this, you want to do primary angioplasty. Is the definitive treatment of choice for this patient with MI, because they also have cardiogenic shock as well. Some people might say you want to start them on a dopamine drip. This can be adjunctive therapy. However, it does increase myocardial O2 demand and can actually cause worsening of the shock. So you got to be careful with that. If you have the, thrombolytic therapy, if you have nothing else, you might want to consider giving that as well. But if you have access to cath lab, primary angioplasty is going to be the way to go. So question 7, 69-year-old male presents ER with intermittent sharp chest pain of several days duration. This brought on with certain movements. His wife says that he noticed him rubbing his chest. He's currently asymptomatic. He had an anterior wall STEMI 6 weeks ago and is taking warfarin. Vital signs include BP of 150/85, pulse of 67, respirations of 14, and O2 sat of 100% of room air. Physical exam is unremarkable. An EKG is obtained, and a prior EKG is not immediately available. Let's take a look at that EKG there. So what is the appropriate next step? A, administer an NSAID, obtain diagnostic echoradiography, start antiarrhythmia therapy, or start thrombolytic therapy. And here you really want to get a, diagnostic echo. And the question here is this a STEMI versus a left ventricular aneurysm? Looking at this EKG, there's no real reciprocal changes. He's got these really big Q waves. He has a history of an MI, anterior wall MI. He's currently asymptomatic. You don't want to give this patient thrombolytics or rush them to the cath lab. Get an echo, take a look to see if there's the, left ventricular aneurysm, and then, treat the patient accordingly. So moving on, too low, this is going to be your ST segment depression. I'm not going to talk too much about this topic, but once again, 6 causes of ST segment depression you should probably be aware of for the exam. Reciprocal changes, subendocardial infarct, posterior MI, which we discussed previously, any kind of ischemia, digoxin, which we'll discuss in the tox section, and then left ventricular hypertrophy. So just kind of going down the list, reciprocal changes, these are going to be visible during your STEMI. So if you have a STEMI and you have ST depression, other leads, typically it's going to be reciprocal changes. Ischemia, you really want to look for, planar or flat ST segment depression. So that's going to be more likely to signify significant ischemia. Looking at other patterns, there's like upsloping, downsloping, but if you have a very flat ST segment depression, you want to think of ischemia for that. And then just to talk real quick about left ventricular hypertrophy, if you have LVH with repolarization abnormality, this is going to equal strain. And this is really only going to be seen in the lateral leads, not anterior leads. And sometimes they'll ask about, is there, if you're trying to determine if there's any kind of left ventricular hypertrophy, I guess it's more clinically. Usually you just look at it and it looks like you have these really tall QRS complexes, especially in the, super lateral leads. So you're like, oh, this person looks like they have LVH with strain. But in case you want to measure it, the way to do it here, I kind of just listed, which you can look kind of at your own here. And then additionally, you can have some left atrial enlargement, which is going to look like a big P wave and, big box, especially in like V1. And here's just an example of your LVH with strain. And you can see there's some PR or some ST depression secondary to the strain there. So question number 8, 52-year-old male presents with substernal chest pain radiating down his left arm, shortness of breath and nausea of 30 minutes duration. He denies other complaints. His only medication is tadalafil for erectile dysfunction, which he took the day before. Vital signs include blood pressure of 160/95, pulse of 87, respiration of 18, and an O2 sat of 99% of room air. Physical exam is normal and an EKG is obtained. He has persistent pain despite administration of aspirin and morphine. Which of the following statements regarding the next step is correct? A. Activation of the cardiac cath lab is warranted. B. Administration of NSAIDs for persistent pain is an acceptable treatment approach. C. Administration of sublingual nitrogen for ongoing ischemic discomfort is an acceptable treatment approach. Or D. This patient meets criteria for thrombolytic therapy. The answer is going to be A. Activation of cardiac cath lab is warranted. So why is this? Looking at the EKG, this patient does have basically like depressions and inferolateral leads. In addition, he's got this chest pain, which is ongoing, concerning for ischemia. So I think, in the setting of that, basically the American Heart Association says that if you have, the treatment's going to be early invasive therapy for a patient with the, unstable angina or STEMI who has refractory angina, such as this patient here. Some people might have said, well, let's give him some nitroglycerin and see if that helps with this pain. However, this patient basically had an erectile dysfunction medication, tadalafil, approximately within 48 hours prior. So this is actually a contradiction to any nitrates. So you don't want to give this patient nitrates. And then if they don't have an IVS STEMI, you're not going to give them thrombolytics. You can take them to the cath lab, take a look at the vessels, see if he needs any kind of intervention there. But you don't want to just throw thrombolytics at someone who's not having an actual STEMI. So moving on to our next section, it's going to be too toxic, which is going to go over some drugs you need to know for the exam. The big ones are going to be digoxin and your tricyclic antidepressants. Also beta blockers and calcium channel blockers might be in the exam. So going over to digoxin, this is sodium potassium ATPase inhibitor. So this is basically causing inhibition of this ATPase. Symptoms for digoxin toxicity, you're going to have GI symptoms, nausea, vomiting, anorexia, diarrhea. The big one you want to know for vision is going to be this yellow-green discoloration that people might kind of talk about. You can have palpitations, syncope, dyspnea on exam, confusion, dizziness, delirium, fatigue. So when thinking about the EKG, what are things we want to look for to kind of suggest digoxin toxicity? When you look at the ST segment for, basically on the EKG, you might see this like swooping or sagging pattern. They call it basically like a Salvador Dali mustache pattern, which is pretty, something that they might test on and you might see on the EKG. You might also see flat and inverted or biphasic T waves and then a short QT interval. Classically, digoxin can present with just about any kind of arrhythmia or dysarrhythmia. But the big one, the classic one that they're going to, test you on a lot is this combo of basically a SVT with a slow ventricular response. So you'll have this increased automaticity with a decreased AV conduction. And what this presents like is an atrial tachycardia with a block. Additionally, the most common abnormality they might ask about is you're going to have frequent PVCs. And this might look like a ventricular bigeminy or trigeminy. You might see any kind of block, sinus tachycardia, junctional bradycardia, like I mentioned before. Always want to consider digoxin if you see junctional bradycardia, and then ventricular tachycardias as well. So here's the EKG, just kind of showing this the ST segment with the kind of swooping Salvador Dali-like mustache. And then here's some of the arrhythmias you can see with digoxin as well, and it almost looks like a slow atrial flutter, atrial fibrillation. So you have that kind of like atrial tachycardia with block. And then here you have your, kind of like your basically your ventricular arrhythmia. with two different kind of like morphologies of the QRS complex, and then below we have our PVCs with our bigeminy. So treatment for this, the one that they'll probably test you on is going to be given your digoxin specific fab fragments. That's the treatment of choice. Really, the indication for this are malignant dysrhythmias. If you have a potassium greater than 5.0 or a digoxin level greater than 15 acutely or greater than 10 after 6 hours of ingestion. You can also give decontamination, IV fluids for supportive care. You want to give atropine if they have a bradycardia and a high degree AV block. Consider pacemaker maybe. However, you want to avoid transvenous as the myocardium is extremely sensitive, and the last thing you want to do is trigger some deadly arrhythmia. Just a pearl to know, if the potassium is greater than 5 on acute ingestion, this is a poor prognosis for the patient. So moving on to TCA toxicity, tricyclic antidepressant toxicity. This is a sodium channel blocker. It has quinidine-like effects, so type 1A-like effects, which causes the QRS widening that you'll see with TCA toxicity. Additionally, if you look and lead AVR, you might see like a terminal R wave or an R prime, which is pretty big. It's going to be about greater than 3 millimeters. So if you see that, looking, AVR, that's going to be suggestive of TCA toxicity. It also has some other effects as well, and then things that you'll notice: arrhythmias, hypotension. So here's a very typical EKG for TCA toxicity. As you can see, you have that kind of like wide QRS looking pattern, and then if you look in V1, you have this, AVR, you have this basically R prime kind of pattern where it almost looks a little bit notched. And here's just kind of a little bit of a better example of that. So if you see that, very common for TCA toxicity. Treatment, you want to give sodium bicarb if they have a widened QRS, which they probably will have if they give you an EKG on this in the exam. Consider activated charcoal if it's soon enough. There's been cases where you can give 3% saline for acute cases, norepi for hypotension, for activated fluids. And then you want to avoid certain types of antiarrhythmics as well as beta blockers and calcium channel blockers, as they can worsen this. And then Pearl, just, if they have seizures, obviously just like anyone else, you want to give benzos, but just kind of Pearl is phenytoin is going to be ineffective based on the sodium channels and everything for this. So just a quick talk on beta blockers and calcium channel blockers. Beta blocker toxicity, you're going to get hypotension, bradycardia. If they have a known history of taking beta blockers, obviously classic answer is going to be glucagon. You can also give insulin and glucose. For calcium channel blocker toxicity, hypotension, bradycardia, and AV blocks, treat this with calcium, which is classic, and then they have like a euglycemic therapy, so you give insulin, glucose. You can also try glucagon and pressors as well. So question number 9, a 30-year-old female presents after acute ingestion of amitriptyline and is intubated for airway protection. An EKG is obtained. So what is the most appropriate treatment here? It's going to be sodium bicarbonate. So obviously, we just talked about this, TCA toxicity. They have a wide QRS. You want to give sodium bicarb for this. So moving on to metabolic, kind of going over some electrolytes and hypothermia. So potassium, magnesium, calcium, thyroid hormone are going to be, or potassium, magnesium, calcium are the big electrolytes, and then in terms of other metabolic, thyroid and hypothermia. So potassium, is the big one, kind of starting with hyperkalemia. You want to really think of like a dialysis patient here, someone who's had significant rhabdomyolysis, someone who's on potassium-sparing diuretics or other medications, acidosis, and then really you want to think of us. One of the main causes of hyperkalemia is because we give patients, too much potassium through the IV, and then they become hyperkalemic. So progression of EKG, this is usually something that you should be very familiar with. You're typically going to see peak T waves, flattened P waves, and increased PR interval. This is going to be followed by more of a widening of the QRS, which is going to then kind of develop into deep S waves and merging of the S and T waves. And you're going to develop this idioventricular rhythm, this sine wave formation, and this is going to kind of end up going into ventricular fibrillation and cardiac arrest. So here's kind of a good example of progression of the, QRS complex and T waves with, as the, basically as you become more and more hyperkalemic. And then there's a nice example of a very wide sinusoidal sine-like pattern secondary to significant hyperkalemia. So you always want to know the treatment for this. They might just give you an EKG, tell you the patient's a dialysis patient. It'd be like, what's going to be the appropriate treatment for this patient. If they have widening of the QRS, you want to give them calcium chloride or gluconate for membrane stabilization. Only want to give this if the QRS is wide. Other medications you want to give, sodium bicarb, which typically you only give in acidosis, insulin and dextrose, beta agonists, and then you want to get the potassium out of the body. So ways to do that, you give furosemide or Lasix, which helps you pee it out, K-exalate, which there's a little bit of controversy with that now. Most people are saying don't give it, but I think for the exams, you'd still probably choose K-exalate if they have it on there. And then, if all else fails, dialysis is going to be the best way to get that potassium out. Hypokalemia, you want to think like GI loss, eating disorders, or anorexia, bulimia, any kind of hypomagnesemia, familial hypokalemic periodic paralysis, again, renal disease, diuretics, Cushing syndrome. EKG findings for this, you're going to have flat T waves, U waves, which are going to be very pathognomonic for hypo-K, prolonged QT and PR, broadening of the QRS, and then any arrhythmias or PEA. Pearl, hypoglycemia or hypokalemia does exacerbate Digoxin toxicity. Once again, here is just an example of progression. As you get more and more hypokalemic, you kind of lose your T wave flattens out, you develop the U wave, and there's a good example here. So treatment for this, obviously you want to minimize further GI loss, give potassium replacement, and then you want to correct your other electrolytes like magnesium and phosphate if they're deficient. A pearl for this is in if you do have a patient with hypokalemic periodic paralysis, this can be triggered by large carbohydrate meals. So you do want to give a small amount of potassium to these patients. Mostly oral. You almost never want to give IV potassium to these patients. You want to monitor them. The thing with them is that their whole body potassium is actually normal, but what happens is basically when they eat high carbohydrate meal, they release the insulin. The insulin causes a shift of the potassium, and this develops basically like a pseudo-hyponatremia or pseudo-hypokalemia. So if you give them a lot of IV potassium and then it corrects themselves, you can actually overshoot and cause significant hyperkalemia, which can result in death with these patients. So give only oral potassium, monitor. Okay, moving on to magnesium. So just to talk a little bit about hypomagnesemia, EKG findings, wide QRS, prolonged PR interval, ventricular arrhythmias, and obviously prolonged QT can go to torsades as well. So calcium, just talk about hypercalcemia. You want to think about hyperparathyroidism, patients with cancer, sarcoidosis, multiple myeloma, vitamin D toxicity, or hypothyroidism. EKG, you're going to have QT shortening, PR prolongation, widened QRS, and you can actually have a notched QRS with increased voltage, and I'll show you a picture of that on the next slide. You can also develop AV blocks, which can progress to complete heart blocks and cardiac arrest. And here's just an example of hypercalcemic EKG here, and as you can see, you have this notching in the QRX complex. So for hypercalcemia, what's the treatment here? Volume expansion, number one, give lots of fluids, get that calcium down. You can also give calcitonin, bisphosphonates, hemodialysis if you need to, and then you can give Lasix as well to help get some of the calcium out. But you want to make sure you give lots of fluids first, and then if they become fluid overloaded, then you can give your Lasix. So just a quick talk on hypocalcemia. Think about any patient that's hypomagnesemic, pancreatitis, hyperparathyroidism, post thyroidectomy, any form of alkalosis, meds, massive blood transfusions. EKG, you're going to have more of a prolonged QT, unlike hyperkalemia, where you have a shortened QT, and hypokalemia, you have a prolonged QT. And this can trigger torsades. Treatment for this, underlying cause, calcium replacement, magnesium if they develop, torsades. And here's kind of just a picture of prolonged QT secondary to hypocalcemia. Just to talk real quick about thyroid, for hyperthyroidism, obviously this is a state of adrenergic hyperactivity. EKG is most likely going to show sinus tachycardia. For hypothyroidism, sinus bradycardia, and then you can also have these kind of like diffuse flattened or deeply inverted T waves. And I'll show you EKG here that shows these bradycardia with these deep kind of T waves, which is consistent with the hypothyroidism. And just a little environmental talk here is talking about hypothermia. Really, the EKG could show just about anything for hypothermia. You get sinus bradycardia, you get AFib with slow ventricular response, you can get PVCs, V-tach, V-fib, asystole, And the thing that you really are going to see, it's going to be pathognomonic, are these Osborne J waves, which I'll show you in the next slide. Just another pearl, defibrillate if warranted, but don't try multiple times. Most hypothermia-induced arrhythmias convert spontaneously during rewarming, and defibrillation really is rarely going to be successful, especially with severe hypothermia below 30 degrees Celsius. So try once or twice. If it doesn't work, do your CPR, get them rewarmed. Once you get them above a certain, temperature, if they still haven't converted, then you can go ahead and try defibrillating again. Okay, and here's an example of a hypothermic EKG. In case you can't see it, this is basically what these, Osborne J waves will look like. So a little bit of this notching kind of at the end of the QRS complex. So question number 10. 41-year-old male presents unable to walk after Super Bowl party. Physical exam is normal except for flaccid paralysis of his legs. The cardiac monitor reveals the strip below. He has a family history of this problem. So which of the following is the most appropriate treatment? A. Calcium gluconate, B. Magnesium sulfate, C. Potassium chloride, or D. Thyroxine? Your answer is going to be C. Potassium chloride. So what does this patient have? If you look back on the rhythm strip, it looks like he's got these U waves and flattened T waves, so consistent with hypokalemia. With a family history of this problem, this is likely secondary to familial hypokalemic periodic paralysis. This was probably exacerbated by a high carb meal that he had while at the Super Bowl party, and you want to give PO potassium for this. Like I said, kind of avoid the IV stuff. You don't want to overshoot. This patient's not gonna, probably, they can basically handle a little bit of the low potassium, so give them oral replacement, and then they should basically, monitor them, and they'll kind of go back to normal state. So moving on, too scary. These are basically the conditions you really don't want to miss on EKG. If you discharge these patients or don't admit them, don't get further workup, these patients can come back dead or in significant arrhythmias. So you don't want to miss these. So these are the scary ones. So we have cardiac tamponade, hypertrophic cardiomyopathy, Brugada syndrome, Wellen syndrome, and your long QT syndromes. So for cardiac tamponade, typically you want to think of a trauma patient, someone with maybe a dissecting aortic aneurysm, or even you can have like chronic cancer patients, infections, patients like that could present with cardiac tamponade as well. EKG, you're going to have a sinus tachycardia. You want to look for any kind of low voltage in a QRS. You might have some PR segment depression. And then the EKG finding that they most likely will give you an EKG, it's going to show electrical alternans. And this is basically when you have alternating size and morphology of every other beat, which is caused by basically the swinging of the heart inside the pericardial sac, because there's so much fluid that the heart's actually swinging as it beats. And that's why you get these different QRS kind of morphologies. Here's an example of that. As you can see, it kind of goes short, tall, short, tall. That's basically your electrical alternans there. You want to consider pericardial cardiac tamponade. So if stable, which they're not likely going to ask you about because obviously cardiac tamponade is not a stable condition. You want to resuscitate this patient, take them to the OR for pericardial window. If unstable and they have vitals, you want to do pericardiocentesis. If this is, for example, a trauma patient who had penetrating traumatic injury and they lose vitals in the ER, then you want to do your thoracotomy. Moving on to hypertrophic cardiomyopathy, you want to think young athlete presenting with exertional syncope, palpitations, chest pain, known history, family history of early death. Your EKG here, you're going to have left ventricular hypertrophy with basically very large precordial voltages. You might have these deep, narrow, dagger-like Q waves in your lateral inferior leads. You might have some left atrial enlargement, and then you might have giant precordial T wave inversions as well. And here's kind of EKG that they might show you for a patient with hypertrophic cardiomyopathy. As you can see, you have these very dagger-like Q waves, especially in the lateral leads where the arrows are pointing, as well as these tall R waves and inverted T waves. So treatment for this, admit with cardiology and consult. Likely they're going to need an ICD placement. Also, patients like this, they'll probably end up being placed on a beta blocker, calcium channel blocker, as this will slow their heart rate and improve diastolic function. Brugada syndrome is another one you have to look out for. You want to think of a younger, possibly Asian male who presents with a syncopal episode. This is a sodium channelopathy and really can be unmasked or augmented by things like fever, drugs, electrolyte abnormalities, or ischemia. And when you look at the EKG, there's three types of Brugada type patterns. The one that they're most likely going to test you on is going to be the type 1, and this is going to have basically you're going to have a coved ST segment elevation greater than 2 millimeters, and at least basically greater than 1 of either V1 to V3, and this is going to be followed by negative T wave or inverted T wave. And here you can see this Brugada-like pattern. This kind of it's basically an elevation with this kind of nice slope down, and then you have an inverted T wave here. If you see this is Brugada's. Admit the patient, don't send them home. They're going to need further workup. They'll need a ICD placement. So admit to cardiology for ICD placement. Next one's going to be Welland syndrome. This is really basically a condition that's highly specific for critical stenosis of the LAD. So this is an EKG finding, and if you see this, there's significant stenosis of the LAD, and this patient cannot go home. Basically, they might be pain-free at the time the EKG is taken, or they might have minimally elevated enzymes. However, this is very, very high risk for extensive anterior wall MI within the next few days to weeks. So EKG, what are you going to see? You're going to see these deeply inverted or biphasic T waves in these V2 to V3. You might see an isoelectric or minimally elevated ST segment, no precordial Q waves, and like I said, the patient's going to present in a pain-free state most of the time when they have this. And here's an example of your Welland syndrome here, and you can see this kind of like biphasic, this biphasic kind of T wave. And here's another example here. So once again, you see this in EKG. Patient had history of recent chest pain. Even if their enzymes are negative, very concerning for LAD infarction. And here's another. This is going to be type B. These deeply inverted T waves. So treatment for this is going to require invasive therapy such as catheterization. If you stress test this patient, there's a chance they could just drop dead from an anterior wall MI. So this is not the kind of patient you want to stress test. You just want to go directly to invasive cardiac catheterization. And just to talk a little bit about prolonged QT syndromes, when you have a prolonged QT speed greater than 450 milliseconds, this can predispose patients to malignant ventricular arrhythmias. You want to think of a patient with syncope, cardiac arrest, family history of some cardiac condition. There's a lot of different things that can cause this, including drugs, genetic conditions, myocardial disease, electrolyte abnormalities. And the treatment for this is really going to be treat the underlying cause, consider maybe cardiac pacing, beta blockers, ICD, and genetics. So some more questions here. Question number 11. 34-year-old male presents after his wife reports that he passed out while watching TV. He has no past medical history and is currently asymptomatic. Vital signs are within normal limits and the physical exam is normal. An EKG is obtained. And there's your EKG. Which of the following is the most appropriate next step in the management of this patient? You can A, activate the cardiac cath lab, administer aspirin and heparin. B, admit the patient for cardiac monitoring and consultation for ICD placement. C, obtain neurology consultation for possible seizure disorder. Or D, send cardiac markers and obtain echocardiography. Okay. The answer here is going to be admit the patient for cardiac monitoring and consultation for ICD placement. So as you can see in the EKG, if you look especially in leads V1, V2, that's your Brugada type pattern there with your ST segment elevation with that downslope and then inverted T waves. So you see that, they're basically telling you the patient's asymptomatic, he's young, he's coming in, they're showing you this EKG. This is going to be someone that you're going to admit to, for cardiology consultation for ICD placement. Question number 12. 40-year-old woman presents with progressive shortness of breath of 5 days duration. She has a history of CKD and is on hemodialysis. Vital signs include BP of 95/50, pulse of 110, respirations of 24, and an O2 sat of 95% on room air. An EKG is obtained. While waiting for chest x-ray, she becomes increasingly pale and dusky, and her systolic blood pressure progressively decreases to 70 with only transient response to IV fluids. What's going to be the most effective treatment here? A, calcium gluconate, sodium bicarb, insulin, and glucose. B, dobutamine. C, pericardiocentesis. Or D, thrombolytic therapy. And your answer here is going to be pericardiocentesis. So if you go back to the EKG here and take a look at this, you're going to see, especially if you look at the rhythm strip, very consistent with the electrical alternans. So we're thinking, dialysis patient probably has a pretty big pericardial effusion, which is getting bigger and bigger. Now she's becoming hypotensive. Her, she's having like a cardiac tamponade picture. So you want to, this patient It has a pulse. It's not penetrating trauma. They're unstable. You want to do pericardiocentesis, release some of that fluid, try to get their heart beating, the way it needs to beat again. Okay, question 13. 29-year-old male presents with shortness of breath, palpitations, and lightheadedness only during exertion. There's no history of syncope. His father died suddenly at age 43 years. Vital signs are blood pressure of 143/90, pulse of 78, respirations of 20, and O2 sat of 100% on room air. An EKG is obtained. Which of the following tests will have the highest diagnostic yield? Chest CT, echo, exercise test, or a Holter monitor? And the answer here is going to be B, echocardiography. Going back to the EKG, you could see that this, patient, young patient, coming in with basically shortness of breath, palpitations, lightheadedness during exertion, family history of father dying at a young age. EKG shows these very tall kind of left ventricular hypertrophy with these inverted T waves. The number one thing on your mind should be hypertrophic cardiomyopathy. So that's going to be the answer here. What you want to do is you want to get an echo to look for any kind of septal hypertrophy here. That's going to be the test of choice. So final section here is going to be our 2-pace section and going over pacemakers. 3 things I want to talk about that will most likely be in the exam are going to be undersensing, oversensing, and failure to capture. Undersensing, this occurs when the pacemaker fails to sense a native cardiac activity. So this results in this asynchronous pacing. So when you look at your rhythm strip, which they might give you a rhythm strip, you're going to look for the pacemaker where it's triggering, and you're going to see is it's not going to really be, it's going to be failing to sense a native cardiac activity. So it's going to shoot even though it's not supposed to shoot. So this is undersensing. In the other spectrum, we have oversensing. And this occurs when electrical signals are inappropriately recognized as native cardiac activity and pacing is actually inhibited. So with undersensing, you're basically, you're shooting out, basically you're pacing when you don't need a pace. And with oversensing, you're not pacing when you should be. So this could be secondary to like large P waves or T waves that the pacemaker is sensing as possibly like a QRS complex or any kind of skeletal muscle activity. So you really want to think of like someone who is exercising, doing repetitive movements. They come in with syncope, chest pain, they have a pacemaker. You want to think oversensing. And as you can see here from the rhythm strip, there's a P wave here. Maybe you thought the P wave, it didn't pick it up, so it thinks it's a QRS complex. It doesn't pick it up, so then it doesn't send out a signal. And this can result, obviously, in things like bradycardias, arrhythmias, if the pacemaker is not working appropriately. Finally, failure to capture. This occurs when the pace stimulus does not result in myocardial depolarization. So basically, you're going to be seeing the pacemaker spikes, but there's going to be no QRS complex associated with it. So things you want to think of here: causes, any kind of electrodisplacement, wire fracture, electrolyte disturbance, MI or block. And as you can see here, you have your pacer spikes with no resultant QRS complex. So final question here, question 14. You have an 83-year-old male presents to ER after experiencing syncope while painting his house. He has a pacemaker. An EKG is obtained. Which of the following statements regarding his condition is correct? EKG reveals a pacemaker-mediated tachycardia that can be terminated by placement of a magnet. The EKG reveals pacemaker failure to capture. C, the pacemaker oversensing is the most likely cause. Or D, placement of a magnet will clarify whether the pacemaker is undersensing. And your answer here is going to be pacemaker oversensing is likely the most likely cause. So why do we think that is? So if you look back here at the EKG, you can see the pacer spikes, and it looks like it's spiking, it's pacing appropriately. So it doesn't look like there's anything wrong with the pacemaker here. However, this person does present while having syncope while he was painting his house. So doing repetitive movements with his hand, painting. So this can present, obviously, if the pacemaker is oversensing, then this patient could end up, not having appropriate paced rhythm, can result in having a bradycardia, which could make him, have a syncopal episode. And that's kind of just what we talked about here. So that's the end of the lecture. Like I said, this is pretty much everything that was presented in this lecture is fair game for what could be on the board, emergency medicine board examination. If there's any area that you felt you needed more practice with, go back, take a look at the slides, or look it up, online for their sources. But pretty much, just be very familiar with your typical EKGs. For the exam, you should be able to answer the question most of the time without even looking at the EKG, just based on the question stem. The EKG is really there to kind of like solidify the answer, kind of like give you just a little bit more information to kind of help you out. So if you know the EKGs very well, you should do just fine with the other questions. So good luck.